The Killer Growth Podcast starts now.
Hey guys, Sam McVeigh here with the Killer Growth Podcast, and today I have Melissa Hall, CEO of Susan B. Allen Memorial Hospital.
Hello. Thank you for having me today.
Of course. Been looking forward to it.
Yeah.
It's be fun. We don't know each other at all. We literally just shook hands and talked for 2 minutes.
We did, yes.
That's about it.
Yeah.
So, but I've heard good things.
Thank you.
And excited to hang out and learn more about what it's like being a CEO of a hospital. And how do you become a CEO of a hospital?
Oh my gosh.
That's where we're going to start.
Okay,
I think you obviously have some medical background I don't know about.
Yes, I do. Fun fact, I'm a very goal-driven person. It was never my goal to be a CEO of a hospital. No joke.
that they say is the recipe of a good CEO.
Oh, well,
right?
I'm hoping,
Yeah.
I'm trying.
Okay.
But so truly my background is nursing. I believe it or not, I actually started in the healthcare field when I was 14 as a candy striper. Back in the day, we used to have those. They were volunteers. And we just went around and filled ice cups and that kind of stuff, visited with patients. That was our job.
Where was that at?
I did that at Newman in Emporia, Kansas.
Cool.
My sister actually worked at Dolly Madison, so I would ride to her. She'd drop me off. She'd go to work, and then she'd pick me up. So that's how my summer days went. So
that's cool.
Yeah, that's how it all kind of started.
Yeah.
And then, my grandmother was actually a CNA at a hospital in Burlington, Kansas, which is where I grew up.
Okay.
Born and raised there in a farming community, primarily farming community for a long time. So my grandma actually kind of instilled that just nurturing, giving. She was a farm wife for a lot of years. My grandfather ended up passing away, and she had a lot of hospital debt. And so true story, she walked into the office to say, I can't afford to pay my bill. What do I do? And they said, well, do you want to work it off? And yeah, so they, at that point in time, they didn't actually have like CNA classes. It was just on the job training. And so that's how she paid off her hospital bills. And that's how it all started.
Wow.
Yeah. So my grandmother is probably one of the most influential people in my life. She just taught you from a very young age that if you just work hard and you just keep going, it's all going to work out, even the hard things in life you can learn from. And so another fun fact, while I was in high school, I tried to get a job. I'm like, my mom and dad were like, you need to make your own money.
Yeah.
And so I was like, well, I don't know what to do, really. I didn't really want to work in fast food. But I think it's like a passage of right, you know, you have to. And so I worked at Dairy Queen for a while. And then...
I miss Dairy Queen. We had one here for a long time.
It's just good ice cream.
Good.
I mean, let's just be honest
and the
about
chicken
it.
strips were fantastic.
And the dip 'em in gravy, it's perfect.
Exactly. Yeah, you only got the gravy.
Yeah. So my grandmother was like, hey, you should just try out being a CNA. And I'm like, yeah, okay, like I could do that. So then I did the volunteer thing at Newman's. And then I'm like, I could really do this. And so I started working at the assisted living facility in Burlington, and my grandmother's actually who trained me.
No way.
Yeah.
So were you still in high school at that point?
I was,
Wow.
yeah. And so I actually would go in before school and serve breakfast, and then help do as many dishes as I could before school, and then I'd go to school, and then usually...
I was not that motivated in high school. I would have not got up to do anything before school, period.
So honestly, I've always kind of been an early riser, so that part's not hard, But yeah, I mean, that's kind of how it all started. And then I actually, my junior year of high school, my parents, I grew up the typical farm family, right? Like my dad, I mean, we ate so many family dinners in the field because that's where our dad was, and so my mom would cook dinner, we'd pack it up, and she was very adamant that we all ate as a family together. And so we did that. And so I think that's kind of where that just work ethic, like you just got to do what it takes, And so I was going to be in ag business. I mean, that's what I was going to do. Kind of carry that torch, but from another direction, because I did not want to work in a field all day. Right?
Sure.
That was not my. Bless them.
Bless them.
Lots of summers on a hay wagon for me, and that was I don't want to do that
enough.
forever. Yeah,
that's all right.
Yeah. So then my sister actually ended up having her third child. He was a preemie, so he came 3 months early. He weighed 2 pounds and 10 ounces, right? And so he was in the NICU for 14 weeks, the first 14 weeks of his life. That's where he lived. And it was super impactful for me. I had the opportunity. I was the one that could kind of take my sister up in the evening, so I'd get out of school, and because she couldn't drive, she had some medical conditions going on. And so it was a lot of car time. And we had the opportunity to just kind of feel and share that experience. And I'm like, wow, these people are really making a difference. I mean, my sister talked more about the people that helped her through that journey than the actual situation and the stress of all of it, right? And so that's actually...
they probably kind of become a family at that point.
They
14
do.
weeks, and they're kind of raising your kid. And
Yes. And, there were days that, unfortunately, she just couldn't get there every day. And so you kind of have to, have this sense of, do I trust you, right?
Yeah.
And so I thought, that's kind of cool. I feel like I want to be a part of that. And so... not my mom's favorite day of the world, because I literally flipped everything up, right? I had my college picked, I had all this path, and she's like, you want to do what? I'm like, yeah, we got to start all over, right? We got to pick new colleges. We got I don't know, we got to go see new programs. So my senior year, that's what I spent my time doing was finding the school that fit me. I ended up going through an associate's program. I was more of a it's just kind of how you're raised, right? Like let's hit the ground running, hit the workforce, start your life kind of thing. Let me back up. I actually started at ESU. I thought that's where I wanted to go.
is that Emporia?
It is, yeah.
Okay.
Yeah, and they have a nursing program I was super excited about. I started working for this gentleman, and I ended up falling in love with his nephew. And so my path changed a little.
Sure.
So met the love of my life, truly mean that. Henry, he is my biggest supporter. I mean, truly, when I say I didn't have the goal to be a CEO, but I definitely have the support at home that makes that an option, right? So he does a lot of things that I don't think most husbands do, and he really just does them, right?
Stop making us look bad, Henry, okay? Stop setting the bar so high.
Yeah. So we got married pretty young. I was 19 when we got married.
And how old was he?
So we're 3 years apart.
3 years, yeah.
Yeah. And so, but when and so.
So funny enough, my wife was 19, I was 21.
Okay. So yes.
Yes. Very similar.
Yeah. So, and lots of people are like, oh my gosh, you're 19. This will never work out. 26 years later,
Right.
we're still going,
That's awesome.
and honestly, I would say probably stronger today than any time. Right.
Yeah.
And so that was truly a blessing. Thankfully God put us in the right paths and we crossed. But it did make me choose a new school for nursing. And so I started an associate's program through Ottawa, and, we made it through nursing school, which I don't know if anybody knows this, but that's a hard degree.
Yep.
That is, it's challenging, it's intense, it's rapid fire all the time. And so a lot of stressors.
Yep.
But we made it through. And then I started working at Stormont Vail in the labor and delivery department. Because, my calling I felt like was to be around these babies, right? And really be a part of that. And I got to experience firsthand to be on the nursing side of that care that my sister received all those years before that. So
That's cool.
just really cool, full circle. That is truly, it's just truly a passion of mine. There's just something amazing about bringing life into the world. So I got to be a part of that. And then my husband and I were blessed with our first one 3 years later. And so we decided living that far away from our families doesn't really make sense. So we moved to a small town, Lebo, Kansas.
Oh, yeah.
Yeah. So
Panasonic.
So we moved there. I started, which, I was commuting for a while, back and forth to Topeka 3 days a week. It's not so bad. But when you got a little baby at home, that gets harder and
that'd be
harder.
hard.
And so I actually reached out to the local hospital in Burlington, Kansas, again, right? That's where I started it all, in high school. And so I said, hey, I don't know if you guys have nursing. Like you're a lot smaller than Stormont. That's been my exposure. And they were like, oh my gosh, yeah, we'd love to have you, but probably in surgery. Like that's where our opening is right now. And I'm like, all right, let's learn surgery. So we did that. And then of course, because you have a skill set, small hospitals are so very unique. It took me a little bit. I actually jokingly, but with all the love in my heart, say I did go home about 3 months into working there, and I told my husband I have committed career suicide. Right? I'm like, oh my gosh, okay, but it's okay because I'm going to focus on our family, and that's going to be okay. But actually, what I didn't know then is what I know now, and that is rural health has a just true niche, and you get to see all facets, right? Yes, some days are hard because you truly have to figure out how to do things that at a big hospital you have every specialty for, right? At a big hospital we had a team that came and started our IVs. Now all of a sudden I got to start all of my own. It's just some things like that are, you feel like they're backwards, but really as a nurse, my skill set grew so much. The other thing about a small hospital is you kind of do whatever it takes. So my director of nursing came to me one day. She's like, we have all these gaps in our ER. Do you want to learn ER? And I'm like, I don't know. And she's
Do I
like,
have to?
she's like, it's not going to be that hard. You'll be fine. And I'm like, she's like, it's a lot like recovering a patient. I'm like, okay, she lied. It's not. It's not. It's different. But it was still good. It's still a skill set that I, got to learn and just be a part of. But the other part of that is you truly get to see how the whole hospital works. In a small hospital, you have to.
The correlation of big business to a small business, everything you're saying sounds like somebody that's, starting a business and they have to do the bookkeeping and do the jobs and take the calls. And
yes. You don't just get
Makes
to
sense.
do your niche.
Right.
It's all of us
Gotta
have to
wear a
come
lot of
together.
hats.
Yeah. And then, so really that kind of progressed to, I kind of like computers. I don't know. It's never been a thing I've oh yes, I want to learn IT stuff. Right. But it kind of comes natural. And I'm like, I kind of get how things all work together.
Yeah.
And so at the time, the person that was over our IT department said, hey, we got to take this new update. Do you want to help us on the clinical side build the assessments? I'm like, yeah, because whoever built them to start with did them all wrong. Right? I'm like, let's build efficiency. And she's like, well, then come be your own voice. And I'm like, okay. And so that actually started me on a whole new path. And so then I did end up leaving Burlington, and I went to Newman's, and I actually ran their clinical package in their IT department.
Oh, wow.
Yeah.
At the hospital in Newman?
At the hospital at Newman, yeah. And so, but my main focus was the physician clinic offices. So we had surgical, pediatric, orthopedic, and then just one primary care clinic. So it was a whole conglomeration of things. I would say at that point, that's probably the most pivotal moment of my career, because you truly learn every part of a hospital. You learn the billing part, right? Because everything we do clinically, we only get paid for if it drops to the bill, right? And so I learned all of that part. I learned how medical records works, just from how are all these files stored and all of the pieces. Of course, just being involved in IT, there's a lot of security that comes with that. Definitely not my specialty, but you have to learn some.
Yeah.
And so then randomly, one day I got a phone call from the CEO at Burlington, and she said, hey, we have this chief nursing officer position open. What do you think? And I'm like, oh, I don't really know. I've really never thought about going into that level of management. And she's like, oh, just come down and visit with us, And I'm like, okay. And so I went there, and I'm like, you have to find a different way to make a change, right? So the whole reason I got into healthcare was because I wanted to be a part of something. And you have this almost instant gratitude and glorification of when you get to go home, today you changed someone's life, right? They can have the worst day. Most of them are.
Yeah.
They're in the hospital, right? But you can make it really good if you have the right mindset to do it. You kind of walk away from that a little bit when you come to the management side. And so I had to find a new path, right? I had to find a new way of how do I still get my cup filled?
Right. Yeah.
And so I really kind of took it from an approach of, I'm probably not the one that's going to do it at the bedside, but I can help the next nurse do it and help her do it easier and better, right? And so that's really kind of became my focus. I still dabble, right? So I won't lie. It's hard to just completely walk away from the clinical side of things. So that's so I did that for almost 10 years, and it was great. Like learned a lot, ran a lot. Again, in a small hospital, so it wasn't like my title was chief nursing officer, but I was really over radiology and lab and respiratory. Yeah. So kind of learned everything and just kind of how it all worked. And then had the beautiful opportunity to come to El Dorado and be the operations officer. And I think it's really powerful that I can sit in a meeting, even at that level. I could sit in a meeting and say, right, but the people that are doing the work, that doesn't make sense for.
Yeah.
Right? Like, so it's a little bit different. Like,
100%.
Do you know what I'm saying?
Oh, yeah. Well, I think of, so my wife's educator at Butler in the nursing program. She went through the RN program at Butler and had 2 kids while she was going through it in the 2-year time period.
Yeah.
So you guys, married at 19, you guys have some similarities of that. Like, but yeah, that's a big frustration. That top down model versus bottom up model. I think of Walmart actually is famous for that. They're famous for promoting within. From you could be literally stocking shelves and be the president of a branch. That's how they're built, because there's buy-in and then there's empathy and then community grows. So 100%. Yeah. Everything you're saying is just cool that you were not only on the floor, patient care, then you went into the IT side to understand the back end. Right. And now you go to management, like top of management.
Yeah. But it's really cool. And I can feel your wife's pain. There's some true going through school. I did go back to school and eventually get my bachelor's and my master's. Did all that with a family. Yeah. Bless my husband, right? Like, let's just be honest.
She has a year left on her master's and we're dying on the inside.
Oh my gosh.
She's really dying.
Yes.
It's been tough because she stayed home for like 10 years and then went into the education role at Butler. And it's been a hard transition. And really, it's harder for her, but I'm a baby because I didn't realize how much she did. Let's be honest. Like, I just had no idea how much was going on behind the scenes in my own home.
Yes.
Until I had to step up and do some things. So, but super proud of her. And it's a big undertaking to do both sides of that. But like you said, it's been really fulfilling for her.
Yeah.
She's wanted to be a nurse since she was 6 years old. Her parents still remember, like, it's all she talked about. She was always going to go that direction. And then chose to stay home, and that worked out better for my career. Sure. And then now got in a position where she can go back in. But yeah, you guys are like so similar. It's like you guys need to get together.
Yes, we should. Honestly,
like, oh my god,
we can swap stories.
Yeah.
Like, listen.
Gosh. Yeah. Anyway.
Yeah, but yeah, we.
So you're in. So you go into the COO role at SBA.
Yeah, and so really just kind of came with it with a little bit of fresh eyes, those types of things. I chuckle inside a little bit because my team, I'm sure they get tired of hearing me. I'm like, just because we haven't done it doesn't mean we can't, right? And so I brought, just a sense of something different to, Burlington is a smaller scale, but truly it really doesn't function a lot different than how we function at El Dorado. Mm-hmm. There's just more volume here, right? And so I challenge a lot from a perspective of, but could we do it different, right? Like, let's not just have the answer be no because we haven't done it in 20 years. Let's just say, what if we did it? Like, let's really talk through it. And so, kind of did that. And then again, our CEO at the time had some health issues and ended up retiring a little earlier than he or I planned on. And so, kind of the CEO role just felt like the next thing, right? Because I'm already
because you
there.
became interim automatically, right? As with his health issues, and was that succession plan talked about at all prior, or was that kind of just that's farther down the road?
Yes, nobody
people apply or whatever.
Exactly, and honestly, at the time, my youngest was, my oldest graduated. My youngest was still in just middle school-ish, you know, and finishing up middle school. And I'm like, oh, you got to stay in Burlington, right? Like, I mean, the thought of like moving your child when they've gone to school with their friends their entire life, you know, right? Like Burlington is small enough that you have, we met these kids in preschool, right? Yeah. And they've been in that journey together. And so honestly, at home, it was a lot of conversation of, is it the right thing, you know, for our family? And I would say I didn't let our son decide, but he got a bigger voice than I would have normally thought you'd give a 14-year-old. But just from a perspective of, you know, are you willing to pick up and move? And you have to start all over, and high school's hard. Yeah. I mean, it's hard to walk in and not know anyone, you know? And but he was up for a challenge. He just has that personality, which is pretty awesome. So we decided, I'm like, okay, I'm going to throw my hat in the ring, you know, and the board was very supportive. They've been very supportive this entire time. I mean, truly, I won't lie. I walked into, it was kind of a mess. You know, they were, even when I started as the COO, financially, things are not great, a little bit of upside down. And so, you know, I'm like, look, we're going to have to hit the ground running. Like, we can't survive this way. And so, I really give a lot of that to our team. Our leadership team is phenomenal from a perspective of, one, they genuinely care about this community, right? I mean, that's what drives what they do. But they were very willing to, okay, we're going to do what it takes, right? And if I said, hey, we got to find a way to cut these expenses, like what can we give? What do we not need, right? Even if we've done it for 20 years, can we do it differently that's, you know, less expensive? And
you started having those conversations as COO before?
A little bit, yeah.
A little bit,
yeah. You know, as much as I could.
Sure.
You know, we get to do the work, but we don't really get to control the path, right? You know, we're kind of on the path that somebody sets us. And so, and then when I became interim, I'm like, I really became very aware of numbers and really what it looked like. And it was, okay, now we have to, right? we gotta fix some things. And that team has just been phenomenal from a perspective of, okay, let's do it, right? I mean, let's jump in, let's find the way. And we've done a lot of great work. The other side of that we really focused on, we didn't have a great reputation for quality. You know, unfortunately, we went through some things that prior administration, some decisions that they made just kind of ruffled some feathers, which they changed some things. Right? I wasn't in their shoes. I'm not here to judge what they did or what they didn't do. More of I don't know what they were living in that moment.
Yeah. Not a judgment, just a time for a course correction, though, and acknowledging what's real. Yeah. That's okay.
Yeah.
And I that was one of my questions. I was looking up image problem, how to ask you, okay, hey, is there an image problem, or was there, or is it current, or what does that look like? Then I was looking at, you know, in my world, I was looking at Google reviews, and you know that's a tough, anything that's public facing like that, right, is so hard. Yeah. And owning businesses, like it sucks when I get a 1-star review and I can't do anything about it, and I'm like, oh, but I want to tell the other side of the story. But I was, you're at like that 2.5, which I think is a thing to look at from a public facing, and it's only 150 reviews. It's not, you guys see an insane amount of people, right? That's a small sample size. But then I look at, you know, these other hospitals that probably have equivalent or more, but they have so many more ratings, right? So like Wesley has thousands of ratings. They're at a 4.0 or something like that. Right. But they got way more. So like they even have more bad reviews than you do.
Right.
But it's just a way bigger sample size. So it's hard in that context. And I've had a lot of people bring that up to me before, like, well, did you look at this? So that's my question to you, as much as you want to talk about it. Image problem, how is that being addressed?
Yeah. So I mean, I would say from an image perspective, a lot of just, you know, they don't keep anything. Everything gets transferred out. When I got there as the COO, I'm like, we have to make a change in the ER. It's not that the providers were bad. It really isn't. They didn't know how to manage the patient load that was coming through the door, right?
Makes sense.
And so we had a lot of people waiting in the waiting room for over 2 hours, right? We had a lot of people that wouldn't even wait that long, right? They checked in and then they're like, peace, I'm out, and so we have to fix that, right? And so one of the things that I did was I did actually bring in a new provider group. So let me back up. The other side of that is why a lot of those transfers are happening, right? Is you have to have a beautiful connection between your ER and your hospitalist, right? Because your ER can see people and they can say they need to be admitted, but if you have a hospitalist that's like, we can't keep that here, right? And so we tried to...
And for those that are like me that don't understand hospitals, besides how to walk in the door and say I need help, the hospitalist is the final say in the ER. Are they stewarding the ER? Or are they the on-call? What is that?
Okay, so I'm sorry. Yes.
No, you're good.
Yeah, so the ER actually runs itself, right?
Okay.
Right, the provider that's down there is who manages those patients. But at that point, they make a determination of basically three things. One, you go home, right? We can stabilize you. We can give you a prescription, whatever that looks like, set your strain or whatever, and we send you home. Or we need to admit you to the hospital. Rather, that's as you're probably okay, but we probably should keep you overnight kind of look. Or, hey, your blood sugars are so far out, we have to get those under control, right? And we have to
We're going to put you in a bed.
Yeah, we're gonna put you in a bed. And then the third one is, or do we just transfer you to another facility, right? And we definitely have limitations. We can't do all the things that tertiary centers do.
Yeah.
The Wesleys of the world, they're meant to do those things. And so, a lot of cardiology things, we just don't have those. And so we do have to transfer those out.
And so those three options, who's making that final call?
So the ER provider decides which one of those three. From there, if it's, hey, we need to tuck you in or we need to admit you, and we think we can do it here at SBA, that's when the hospitalist gets involved. So that's the provider on the actual,
Makes sense.
You're going to be in a bed at the hospital. And so that's who's deciding that. And so if they don't work beautifully together, there's a lot of, well, I don't know, they won't take anybody,
Yeah.
And
then
so
that's frustrating for everyone.
Yes.
If a patient hears they're going to go, then they're told they're not.
Yeah, it's hard.
Yeah, that'd be a bummer.
Yeah. And so, a lot of that focus and shift came with our new provider group. We have, oh my gosh, like our quality scores from a federal CMS, we actually are required to submit data to them to prove to them that we're taking care of patients at a certain level. All of our quality scores in the ER have improved.
Awesome.
Yeah. So our average just wait to be seen time used to be over 2 hours. It's now under 30 minutes.
Wow.
Right? Like you check in and you're in a room and average, right? Average,
sure.
but 30 minutes or less.
The person listening that had to wait an hour, it's an average.
It's an average. Yeah. But then, and then, so even from that perspective, just getting your hands on them, that gets the process started, that much sooner. Are left without being seen. So those are the patients that checked in and they were like, I'm not hanging out until you have time to see me. That's reduced by almost 75%. Right? Yeah. I mean, so just phenomenal things are going on.
Time frame of, 23 is when you, so that's, we're talking almost three, right at the 3 year mark now.
Yeah. And I didn't actually get
It's hard to target, say
change.
interim though, because interim you probably didn't have as much control as when you were.
My board actually, they gave me a lot of latitude, right? They're like, you know what's here, right?
Yeah.
I mean, I'd been working in it. And so they were like, if you need to make a change, you make a change. The problem is you can't make things happen overnight, right? And so we knew and identified we have to do something in the ER and that hospitalist collaboration side. But we didn't actually get to make that change until February of 24.
Nice.
So, so really we're just at 2 years and they've made all that progress. I mean, it's it's really remarkable.
That's awesome.
Yeah.
Talk to me about the difference. How is Susan B. Allen Memorial Hospital different than other hospitals? Talk about, like the difference from how it works, from who runs it, who owns it,
sure.
to like Wesley, to,
Yeah.
I'm sure that it seems like there's a lot of different kinds of hospitals.
There is, yeah. So we are a rural community independent PPS hospital. So
what's PPS?
Yep. So PPS is how we get paid. So basically, insurance and CMS, Medicaid, Medicare, they say you get paid X dollars for this diagnosis and this problem.
The code.
Yes.
I had a direct
Yes.
primary care clinic owner on, and he
Okay.
talked about the codes. Like,
Yes.
Yeah. You bill per code.
Yep. And
Okay.
so that determination comes off of, they have this magical payer list, right? Well, Medicare does. And
it's already predetermined for the interesting.
Yeah. So regardless of what it actually cost us to make that happen. Right. So we're a prospective payment hospital, so comparatively, that's like Wesley, right? That's how they get paid also. But we are non-for-profit, and we are independently owned, which means we're running ourselves, right? We have a board of directors, myself, our CFO, our CNO have fiduciary responsibility to ensure the hospital is.
Yeah. Not nonprofit and not for profit are different things, correct?
So in our world, they're the same.
They're the same thing.
Yeah.
Okay.
Yeah.
So you said independently owned. Who owns the hospital?
We own ourselves.
Okay.
So truly, there is no mothership that
Gotcha.
owns us.
So is it like board members have stock? Is there
Nope,
like
there's
none
no
of that?
stock.
It's just
There's-
a 501c3 and there's a board that manages it.
Yeah, and there's
Okay.
there's
Got
truly.
it.
I mean, we have to keep our own doors open.
Right.
Yep.
Yeah.
Yeah.
And
No stockholders. There are hospitals around us that are privately owned, and they truly. They have stock owners. Most of them are physician ran, and so they get a part of the profit that comes from it.
Yeah.
That's not us.
Yeah. So board plays a big role in this, obviously. They have a lot of say. Does the board and the committee form a task force to find a CEO, or on the executive side, and then you're reporting to them? Can you explain that relationship?
Sure. Yeah. So that's really what happens is the board, well, in my case specifically, they did create a CEO search committee. And then they were in charge of, hey, you get us some candidates, right? And then I actually interviewed with the entire board. And so all of them had to say all the things. But from a operations perspective, it is my job and my senior leaders' team's job to keep the hospital running and doing all the things that are appropriate. We definitely guide them. From a board perspective, a lot of conversation is, okay, here is where we're sitting. Here are our options. And I usually give this is what I believe is the right choice, and why. But ultimately they have to make some of those decisions if it's fundamentally structurally going to change how we function.
Sure. Yeah. So I'm sure there's certain decisions that go to a vote, like any other board I've been on, and certain decisions the executive director or CEO could make.
Yep.
And then just report on what they're doing. Yep. Is that so? I think that's actually so why is that better care potentially? Why is it better to be independent 501c3 versus why not just sell it? Why not let it turn into something else or partner?
Sure. So there's a lot of, I'm going to start with probably one of my favorite things is to hear the why people come to us, right? Or after they've been a patient with us. Most people don't plan to go to the hospital, right? But once they've had care here, what I hear the majority of the time is, oh my gosh, your nursing staff just took such good care of me. Or, the radiology tech that came to pick me up, like they genuinely cared, like why I was there and what was going on. That's what you get to do. That's what you get to bring, right? Not that those nurses don't have the same compassion and care. They don't have the opportunity to have the time to actually take care of patients, right? The for-profit hospitals, they have to worry about the bottom line.
Gotcha.
It's a lot of dollars drive a lot of decisions, regardless of what that truly from a care perspective means. Here in an independent function, we have a committee that we have two of our lead ER providers, our ER director, our med-surg director, and our lead hospitalist, and myself, and our quality and compliance person all sit in a room, and we really talk about, hey, we had this situation. How do we prevent this from happening? Right? Those happen every month. We're making change. We're improving things all the time, and we get to just decide today we're going to make the change. Right? Those bigger hospitals, they're very formally driven, and a lot of those decisions don't get made at that table. They're made 4 levels up, and if whoever's making the decision actually understands what that looks like.
Talk about nursing. How are you guys handling the nursing shortage? I mean, it seems like it's a mess.
Yeah.
Like all around. I have several relatives that are in the medical industry and nursing, and have hopped around and left it and then come back or didn't come back.
Sure.
How's that being addressed there? In your background, like I think you get it.
Oh,
so like,
yes.
Can you fix it?
Can I fix it? Oh my gosh, I'm trying. No.
Because I heard a stat too. Sorry to interrupt you.
Go ahead.
I heard a stat. It was something crazy. Like 50% of nursing students, like after they graduate, just don't go do nursing.
Yeah.
Or I don't know if that's the right number, but I thought it was like a crazy.
It's pretty significant.
Yeah.
It just breaks your heart a little bit, right? Yeah. So this is one of the things I just truly believe, unfortunately, how COVID got handled, we are now seeing the ramifications of it. And I don't mean that I'm not passing judgment, right? But at the end of the day, we let political views decide care, practice, and model, right? And so it really pushed nursing to their limits. We saw more nurses walk away from the career path of nursing in a 2-year span than we had the 5 years prior to that. That's true stat. You can go look that up. So that's very impactful, right? And so then it also flipped everything upside down. And we also saw contract nursing become a thing. Oh, yeah. It is, it's always been a thing, but there was always just this like 5% group of people that did it, right? Now it is a lot. I actually just had the opportunity not very long ago to speak to a nursing group that's literally graduating in May, right? In a couple of weeks. And they, a good portion, I mean, I would say probably at least a third of the kids in that room were like, oh, I'm going to really just be travel nursing.
Yeah.
And I'm like, oh, but do you understand what that really means? Right. And that's really not how contract nursing was ever intended to be. It was intended to be just hey, my regular routine nurse is going on maternity leave, and so now I need somebody to fill her spot for 12 weeks, 13 weeks, right?
Right. But now it's turning into like
this is
longer,
their profession.
Yeah,
yes, this is their career, so that's hard. We even live at like 31% of our nursing staff is contracts nursing, which is hard.
Yeah.
And so...
And the hard part that's interesting, we can go as deep as you're comfortable talking about it, but I'm like, when you're working next to that nurse doing the same job and the pay is so substantially different, right? Because that's how it works. Like they don't have benefits. They have no guarantee contract. Right. Right. Like it does make sense, but it's also when it's that big of a percentage. And I never really thought about that being the shortage problem and the demand problem. So how many, there might not be a number, but I wonder how many people went to contract nursing, and then have stayed. Like what % of all nursing is contract nursing?
Yeah.
If you guys are at 30.
Yeah, we're at 30. So I can't even imagine.
So
right?
It's probably 30 or more.
Yeah.
Like that's crazy.
I would venture to say we're not abnormal. I mean, in fact, I know we're not, right? I mean, I have the opportunity through the Kansas Hospital Association. I'm talking to other CNOs, CEOs, and we're all facing that problem.
Yeah.
And some have truly had to just shut down units because we don't have, you can't staff it with contract, right? You don't make enough to staff it with contract. And so you choose to close it instead.
Yeah.
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 So.
Yeah. So as the demand signal goes down, those, I just don't know how you balance that though. It's hard. It's like, once they get that experience and they figure out a lifestyle that works around that, then.
Right. They're used to that.
Yeah. I mean, they kind of have all the leverage because
Yeah.
you need that skill set in your hospital. And if they say, well, I'm only going to do it this way.
Yeah.
And if enough of them say that, it's almost like a union thing, but it's not, you know what I mean? It kind of feels like that.
It does
kind of
feel
like
that
they're forming
way.
this union that doesn't exist.
Thing. Yeah. No.
Yeah.
And but I do think, part of that is we do just across the board. You have to give nurses, it's not always, I'm going to back up. Sorry. I would say the average nurse does not go into nursing for the dollars.
Sure.
Right. They go in because they want to care for something drove them to that, or they've just always had, like your wife since the third grade. Like she's like, I just need to do this job. Yeah. And so I think that's what really drives them. And so yes, from a pay perspective, you can't compete with contract pay. I mean, just on a routine full-time position. But what you can give them is an opportunity to truly get to care for patients the way they want to care for patients. They can be a part of that. The other thing that I really love about a small hospital is you will never see a group of people that will rally together so that a mom can make it to a Valentine's party more than that group, right? I'm telling
awesome.
you.
Yeah.
I've seen so many shift that they've came in and just covered for 2 hours so that she can go and do that, because we all want to be all the things, right? We want to work, we want to provide for our family, but we also want to be the mom or dad that's there and that shows up and we're present.
So the contract nurse is a little alienated from that community.
Yeah, they really are. People don't tend to bend over backwards to help that. So,
bed, like nurse ratio to bed ratio or care to bed ratio, is there any benefit at Susan B. Allen versus some others?
Yeah, I definitely say so. We, on average, sit about 4, sometimes 5 to 1.
Okay.
You're going to go to Wichita, and those are mostly 6 or 7 to 1.
Okay.
And they're sicker, right? I mean, it's not just that there's more of them. They are sicker patients because the hospitals our size couldn't keep them, right? Or, I mean, they never even came here to start with. But but for the most part, they're a lot more acute, and that's So,
that's interesting.
Yeah.
Did it used to be like 1-to-1, like way back in the day, or 1-to-2? Like what did it used?
Yeah, I mean,
or is the 1-to-4 pretty been normal?
I mean, I would say it probably was. I mean, there's different phases of healthcare, right? And so when everything transitioned to this concept of value-based care, all of a sudden we call them DRGs. That's the payment that you get for this diagnosis for this duration, right?
Okay.
That whole concept now, we then added an element of, and you have to score this high on quality scores to get your full payment, right? Which I truly believe this. I don't think hospitals weren't doing it before. Somebody just wanted it to be on a piece of paper, right? They wanted a statistic to show for it. But what that made the nursing person do is now my time can't be just all at the bedside. We transition to now we have to do all these documentation things to meet those requirements to actually get the full payment at the hospital level, if that makes sense.
Yes, and I really enjoyed the series Pitt, the TV show about the ER.
Yes.
And they were always complaining about that. They always have to go over there and do their thing.
Yes.
So
Yeah. And
that's
it's so, and that's the part that's, when I got into IT, that's no joke. I was like, whoever created this documentation style, wrong, right?
Yeah.
Like, so we got to make it so that it's easier for them to do that. But so I would actually say the nurse to patient ratio actually probably was a little bit higher, but we didn't ask them to do near as what we're asking them to do today, right?
Makes sense.
So, and I would say those bigger hospitals haven't really changed that. They just expect you to literally do it all.
Do it all.
Uh-huh.
Yeah. And at a high level. Then
Yeah.
they get burnout and tired. And
Yeah.
Ransomware attack. What a deal.
Oh my gosh.
Right. You talk about if you're researching like that.
Yep.
Obviously made the news.
Yep.
July of 2025. I've never experienced that. And I think it would actually be really insightful to any business owners, any organizational people listening, anything you want to share on that experience and anything learn from it or.
Sure. Yeah. One, never live through it if you don't have to. Just FYI, you will lose sleep. Two, truly, I have actually named that the event. All of the staff at the hospital, we actually refer to it as the event of 2025. That is a horrible experience. We went from everything's working fine at 2 a.m. and all of a sudden at 3 a.m., one of the nurses calls the IT guy on to call and says, my computer doesn't work. I don't know what's happening. A lot of IT is done remotely. And so he's like, let me remote in and see he couldn't get in. Right. And so immediately his bells and whistles are going off, comes in and discovers all the admin is not accessible. And so, he just turns it all off. I mean, literally, like you literally unplug the server, right? It is, you just turn it off and, okay, now what's the next step? So, hospitals from a perspective,
that's her
sorry.
phone. I thought it was me because my phone was buzzing a second ago.
My apologies.
Hey, I'm in a podcast.
Yeah. Yeah. We, So to go through something like that, we obviously have fail safes. There's firewalls. We have all of these regulations to keeping data safe.
Sure.
And I can honestly say, thankfully, they couldn't actually get into our EMR system. But unfortunately, they did deploy and encrypt all of our other servers.
Yeah.
Right. I mean, we couldn't get to our EMR system, but what was on our actual patient records, they couldn't get into. But unfortunately, you have lots of other servers that do a lot of other things. And that stuff was on there. And so it truly, thankfully, we actually have a recovery program that we pay for every month. We had for several years.
Almost like you're insured for that event.
Well, so it's basically a safety net. So everything that we have on our system, like all of our servers, are actually replicated
somewhere else
in a data center, believe it or not, in Iowa. Listen, I'm not stirring up a topic. I'm not taking a position, but they are actually very useful and helpful from a perspective of what they do. So ours was housed in Iowa, and so it was a matter of, okay, I guess we spin that up, right? That actually takes 4 days to do.
Wow.
That is not I really thought that was like a 4-hour job.
That sounds complicated.
It's not. Yeah, it's 4 days. We were truly, everything was done by paper, which, unfortunately then meant we truly couldn't serve some of our patients.
Right.
And that event has just been truly detrimental to the hospital. I mean, we went 45 days and we couldn't even create a bill. Right? And so from you're already struggling financially. I mean, all healthcare is, not just Susan B. Allen, but healthcare in general. Most people don't have a heavy cash flow sitting around. To then we couldn't bill. We couldn't even see some patients in our ER because I didn't have a way to get images to our after hours people. You don't really think about it, but we have really just transitioned to all things are electronic, which is beautiful when you want it to be. Yeah. But when you don't have it, all of a sudden it's really hard.
Yeah. So the ransom. You shut the system down.
Yep.
Right. Unplug it.
Yeah.
Start bringing in
our other system
onto new hardware.
So it's all housed there. That's what the data center does.
Oh, sorry.
Yeah.
So you essentially just transition servers. The hardware stayed the same.
Yeah. So what happens is they have an identical server rack in Iowa, set up, right? And now we just have to make our computers talk to that. The fun thing that I really never thought about, when you have something like that, it touches all the computers that are on your network also. So not only can you not access your servers, you can't even use the hardware that's sitting on everybody's desk. So it was, I bought by Best Buy, some of their laptops, I'm like, what's the best deal? How does this work?
Right.
We, I think, ended up having to buy like 40 some ish computers to truly, I'm like, obviously not everybody got a computer, right?
Right.
But we had at least one in every department so that somebody could access it, get patients taken care of, do their thing, and move forward, while our own internal IT team, so all that's functioning. And then they truly had to, after the audit's done, right? So you even have these forensics teams that come through and they're like finding all the ransomware and what does it mean and what does it look like and what all did it touch,
Yeah.
And then they have to literally wipe everything and rebuild our infrastructure again. It's just, seriously, don't live through it if you don't have to, right?
Seriously. Sounds awful.
So I think if I could give anybody advice, actually, I told just a CEO the other day, she was like, we're so small, they're not going to care. And I'm like, listen, we're small, right? We should have not been on anybody's radar, right?
Yeah.
It can happen. It can really happen.
And did the ransom actually come through? Like, was there any email or something that had a number?
So there really was, but never a dollar amount was never even disclosed. So it never even got deployed the whole way. Which, thankfully,
yeah,
right? We got some things turned off, but unfortunately they did lock everything down.
Right,
so
right. They
still
didn't get
got
to
the full ramification of it, but
that's crazy.
Yeah.
Yeah. Thanks for sharing that. That's a good thing to think about, and something I think about all the time whenever I find out another password is put in, not inside our password protection system.
Yes. Don't do that.
Probably and access to other things. Let's talk about the 1% sales tax.
Okay.
If you're good with jumping into that.
Sure.
From my research, you guys, and I don't know if this is about right, but for about $40 million a year is about what the hospital overall billables can hit. Or has hit, I don't know. That's, the best I could find.
Yeah.
And then talking about a 1% sales tax from the city that would go on a ballot in August.
Yeah, the August ballot.
Take us through that processing, how you guys came to that conclusion, what that communication looked like with the city.
Sure, yeah. So we, so the biggest piece of that puzzle is, we've done a lot of work from 23, even before 23, right? We did a lot of work to try to get our ship righted, on the right path. And so as we worked through that, it's still at the end of the day, we still came in at a negative operating margin. And you can do that for a while. You can have a negative operating, but your cash is okay. The cyber event, I would say, is probably the thing that just really put it over the edge, because we depleted our cash.
Yeah.
Truly, we didn't have a lot of reserve. Don't get me wrong, but what we did have, so then we're really pushing our AP vendors out as far as humanly possible, and we're making all of those things happen. And so, and then plus you're not billing for services, or you can't even provide services, right? So income you're used to having, you don't even have. So from that perspective, it's just like a double whammy.
Yeah.
But on a bigger scale, it's nothing, our service lines everything's back up. Our cancer center was the last piece of the puzzle to come back. And we're not even at full capacity yet. Right. And so that was last July. That's a long time. But that's really kind of what led to the sales tax right now. Right. I won't lie, it was actually a consideration when I was interim. It was like, should we, right? Because, when you become very aware of the numbers, you kind of go, whoa, right? But it really wasn't the right time for a couple of things. One, I still thought there was things we could do to get us on the right path. But the other side of that is we had those quality issues, and we had some image things that we had to get taken care of. You can't go ask for something if you're not running your ship efficiently anyways, right? So, from that perspective, we really did, from 23 to 24, we made a $3 million shift.
Wow.
Right? So, it's not a lack of effort. We're riding the ship, and from 24 to 25, we should have seen almost the same. We still would have came in projected, if you take everything before the event of 25, we should have seen that same. I mean, not to that magnitude, because you can only reduce expenses so much.
Right.
But we were really running very efficient and successful with what we were doing, and then that just kind of blew everything out of the water.
Right.
You know, and so
well, and it's hard to find a baseline anymore, and it's hard to probably even project anything till that's all squared away and recovered.
Yeah. And so so kind of worked through that perspective, and it's really, we also then of course got the announcement from the federal government that, hey, we're gonna initiate this rural health transformation program, right? So they said each state's gonna be in charge of their own dollars. You find a way to reduce your healthcare cost, because in 2028 we're gonna start paying you less, right? So Medicare and Medicaid are gonna pay even less than they do today, and they already don't pay.
That was one of my questions. How much does the federal government affect Susan B. Allen?
A lot.
Yeah.
A lot. Yeah. And so truly, for us to be able to make decisions that are sound, that are strong to keep this hospital here for years and years to come, we need a little help to get us through that window, right? At the end of the day, if it's a no vote in August, point blank, someone asked me, does the hospital close in September then? Right? And I said, no, the hospital doesn't close in September. But what it does is it makes us make decisions that are to fix the now, instead of how can we just make it better, right? How do we get through it? Maybe there's different classifications of hospitals, right? There's hospitals that get reimbursed like we do, PPS. There are hospitals that are called critical access hospitals. They get reimbursed on like a actual cost base.
But you can't have more than 25 beds.
But we don't.
To be in that model.
We already don't staff for 25 beds.
Oh, interesting.
So for us, like, we actually fit every component of that criteria, except there are 2 hospitals that are too close to us. They have to be
the 35 mile.
35 miles
I saw
apart.
it was 35 miles, 25 beds.
Yeah. So unfortunately, KMC and Eureka are just too close to us, right? But we serve completely different populations, right?
Yeah.
And so, so there's some of that truly could still work if some legislation would change.
Yeah.
Right. But that also doesn't happen overnight.
Sure.
I will tell you, I have had to be in the political world more than I have ever. I don't even like politics. Like, I'm not, like, I really just kind of just try to keep to my own, right? Like, I have my thoughts, I have my opinions, and I just keep them to myself. But the reality is these lawmakers make decisions that affect hospitals, and they don't necessarily know what that full impact looks like.
Well, and when you drop the payout for Medicaid and Medicare, knowing the inflation that you caused,
right?
It's interesting.
I
mean, it kind of seems like life's more expensive, and I don't understand how the payout works. Is it already too much? Is it, I don't know that side of it, but
sure, yeah.
It seems like all healthcare on the fulfillment side or the services side is struggling. Yeah. So I would assume it's not paying too much.
Yeah, it's not. Well, and I think it's interesting. There's I'm gonna go on a tangent
Wherever
here, if that's
go.
okay. A little
That's
side
a
note.
long format.
Yeah. So healthcare in general, from us, how we get paid to do business is so different than the average service industry, right? So a typical business owner, right? If it costs you $5 in labor, $5 in supply, so it costs you $10. You want to make $5. You charge $15, and the customer pays you $15. Right. In our business, our charge actually doesn't matter, because Medicare has already, and all payers have already decided, we're going to pay you X for this diagnosis, regardless of how long the patient's there, what other comorbidities that they have that make them more complex.
Regardless of how many visits under that same.
They don't. It doesn't matter. Yeah, and so it's truly, there are things that.
So it's essentially like it's a flat rate. And so if you're and certain service companies have that, right? They'll have a flat rate, but they have a little more control and they can up their own rates at any point, right?
Sure. Yeah. Yeah.
Like
and they just charge more per hour if it takes them longer. Right.
If you clean carpet and you charge per room flat rate, then eventually when it's not working out, you can just raise your rate per room.
Right.
But you can't.
And we can't. And the other side of that is we provide service to anyone, right? If you come in through the ER, we're going to take care of you.
Yeah.
We don't want to, nor would we ever, but there are actual laws that prevent us from saying, you can't come here, right? So if someone hasn't paid their bill for 15 years, it doesn't matter.
Can come in.
They come in.
So talk about why it's so hard to get paid. That's a perfect.
Yeah.
It's one thing I was talking to someone about a very large amount of receivables, and I assume every hospital has huge receivables.
Sure.
What does that look like? Why is it hard?
Yeah. Well,
You just had the core of it, I think, right there. Like we can't refuse service.
Right. Yeah. I mean, part of it is just it doesn't actually matter at the end of the day.
Right.
Now there are. So I think two things. One, whoever decided to use this insurance payout plan made it way more complex than it needed to be. Right. So the average person does not actually understand how their insurance even works. Right. So in your mind, I'm not really any different. I'm like, I've paid my insurance premium. I should get a service. It doesn't happen that way. Right. So in healthcare, you have to jump through a lot of hoops even to get approved to even have that service done. Right. And so some people don't understand that I'm paying an insurance premium. Why isn't my insurance paying the whole cost of it? Does that make sense?
Yep.
So then the other piece is you have a lot of insurance. Well, all of them have you're going to pay your deductible, and then that's a flat fee usually, right? So maybe $2,500, maybe $3,000, and then on top of that, you also then they're still not going to pay the whole thing. They're going to pay 80% of it, and you still have to cover this other 20%
up to another sizable deductible.
5,000 or whatever that looks like, right? And so for the average person, unless you understand how that really works, you're like, I am double paying for this. I'm paying for my insurance premium, and the hospital's charging me in addition to it, right? So a lot of people just don't believe they owe it, right? And so a lot of times we have to talk through it. Like we really have to walk through their plan with them. And, it's a way of how you have to do life sometimes, right?
Yeah.
I mean, obviously, all of us would love the premium insurance package that you have to pay $1,000 deductible and then you're done, and everything's covered. Yeah. The reality is most of us can't afford that, right? I mean, so it's a matter of you make decisions based on what your means are, and so some have had to, because insurance premiums just kind of keep going up and up. Some have had to pick deductibles that are really high. Yeah. So, there's a couple around town that are real common, but their deductible, so just out the gate, they have to pay $7,000 before insurance will even pick anything up.
So if they don't pay that, you don't get paid.
Correct.
Wow.
Yeah, because insurance won't give me anything until they've paid their $7,000. Yes.
And the deductible goes to the insurance company.
To us.
Oh, the deductible does go to you.
Yeah, okay. But then
that's right. I guess like the co-pays that
Yeah. So it would come to us, but then and then we tell the insurance company, okay, they've paid
the rest though.
They've paid their $7,000. But whatever and however, and there's a lot, right?
That'd be a big deal if someone comes in with a $5,000 deductible and you perform a $20,000 operation, then you're sitting on that other 15 until they. Yeah. And then what's the delay? So they pay their deductible. How long till you get the other $15K of that $20,000 scenario?
So first, we don't ever get the 20,
right?
Because what we bill to the insurance, again, they don't care. Right. They're going to pay us the flat fee to start with, right? So they're probably only going to pay us 10.
Sure.
Anyways, but of the 10 that we could have collected, we got the 5 from the patient, and then we have to then tell the insurance company, okay, we've collected our 5 from the patient's responsibility. So now it's your turn to pay. It's about a 45-day payout. Yeah. Some payers are sooner. I mean, I want to give credit where it's due.
Yeah.
But for the majority of time, it's about a 45-day delay
after that,
before you see it.
Deductibles met. Is that a real thing? Billing, like we see a bill that never actually transacted. Like we see a bill on some statement of like, oh, this birth costs X and you only pay this. Is that number real? Like my first daughter was she came premature 6 weeks early. They sent in the NICU unit, didn't need it. She was 6 pounds. She was great. No problem. They walked right out. Right. But we were there cause she had jaundice. So we were there for probably like 5 days. Bill comes in, it's like $45,000 or something like that.
Yeah.
And we had good insurance at the time. So we did our $1,500 deductible. Yep. And I was like, man, that's crazy that they had to insurance pay the rest of that. What did insurance really pay?
Yeah, they didn't.
To Wesley. That was at Wesley, 12 years ago.
Sure. Yeah. No, they didn't pay $40,000. Right. And so,
but why is that posted?
Well, so every hospital, every entity, so clinic, physician clinic, hospital, you have to have these codes, right? And you create a charge, and it's truly a conglomeration of everything. Okay. So a lot of things drive the charge. So one, just a bed rate, right?
Sure.
That's just.
And I'm not even questioning the amount.
No.
Right.
But this is just fundamentally, I'm just trying to kind of so fundamentally, and then every piece of supply that they used is also a charge, right? We base those charges. You create a charge. Most hospitals pick kind of a concept that they want to choose their charges off of. And here's what kind of drives it. Insurance companies, this is the best part, you'll love this. Not only do they have a flat fee that this is all they're going to pay you regardless of what you charge. Also, if you charge less than that flat fee, they will just pay you less. No joke.
Interesting.
Yes. So it's the lesser of the two, and that's what you're going to get paid, right?
Okay.
So you have to create a charge that is enough over what their flat rate is.
Yeah.
Right. So we typically pick like 10 to 15% over the majority of our payer, right? So we pick a commercial payer, our highest commercial payer, from a volume perspective, right? We kind of use that number, and then we add 10 to 15% based on the procedure, just so that we can ensure they're not going to pay us less than what we're charging.
Yeah. Mm-hmm. Okay.
Yeah.
And that just creates and they still always short you 10 or 15, basically every time or more.
Or more.
So it's just literally
So there's actually, this is no joke, several actually outpatient infusions. So there's people that just need medication on a weekly, monthly, some daily regimen, right, to sustain life.
Sure.
Not a joke. This is truly what keeps them alive, is their monthly infusions that they get, right? And to have any quality of life. The insurance companies, there's two of them that we've had to work through at the hospital. The insurance company would reimburse us $2,000. The medication to buy it from our dealer, like our wholesale dealer, was $4,000. And we can't charge the patient the difference, because we've said to the insurance company, we'll take your negotiation. We don't actually get a choice. Here's the problem: we're not big enough to actually have a voice in that game. Yeah. Right. Yeah. I do try to negotiate with insurance companies all the time. In fact, we worked really hard. Ambetter is an insurance that is used a lot throughout this community, and for a lot of years, SBA didn't even take it. And so I'm like, we need to fix that. Like, they need to be able to come here. They live here, like all the things. And so our revenue cycle director and I really worked through this. They came back, they wanted to pay us less than Medicaid, which is typically about 50 to 60% less than it actually cost you to do the business. It's not those are real numbers for the majority of things that they're doing. And so we're like, we can't do that. Like, you have to come in a little bit higher. And so we finally did get some negotiation done with that. But typically we're not big enough to have a voice, like Blue Cross and Blue Shield does not care what I'm doing here in El Dorado, Kansas.
It doesn't move the needle for them.
We don't have enough volume for them to, if I said, well, we're going to stop taking Blue Cross. They'd say, okay, like
It'll go down the street.
It'll go down the street, right? Like, so they, that's
Yeah.
that's unfortunately kind of where we live. And I will tell you, small hospitals across the state of Kansas are struggling with that. The Kansas Hospital Association, I kind of referenced them before, but they're they're a really unique association that help a lot of these smaller hospitals and big ones, but really these smaller hospitals come together and have a voice together. And so we're trying to create things at the state level of how can we all work together to get a better price?
Yeah.
Right?
Good.
Because if we're all united, we have a much bigger voice.
Yeah. Kind of like a co-op, farmers co-op. Like, get together and get some buy-down deals. Get some medication buy-down deals right
exactly.
there. Right?
Yeah.
That's really interesting.
Yeah.
Let's jump into the board. I've got 2 questions on board and the 1%. And I got some questions just from some people I know that are really engaged in the community.
Sure.
Some ideas to form a couple of these questions. And the one that I think was really interesting was, I think the public, anybody that's going to probably vote no, they're going to probably be in 2 camps for the sales tax. I mean, there's going to be one that they don't like you, right? Like that's,
Sure.
we all have those.
Yes, yeah.
And then you have the other one that's like transparency. Well, I don't want that money to go there. I want it to go somewhere else, or it's just more of a money thing. Like, if we're going to do this, I want it somewhere else, and not maybe believing that's where the money should go.
Sure.
So I should say 3 actually, because then the other one was the transparency side of it, right? So we can't, the community, even if this goes through, right? They can't see board minutes. They can't see like this, because this is a 501c3. It's not right? And so this public partnership, I'm not sure how that'll be construed or whatever. But talk to those fears of how are you actually going to stop the bleeding even after this amount of money that gets infused? And I think that's like the ultimate summary is like, well, will it stop? Will it still, after 10 years, will it just go back to where it was? And you've already talked about some of the bleeding you've stopped.
Right, yeah.
But just speak on that.
Yeah, so some of that, like I said, this kind of gives us the time to explore those, like what part of the legislation, right? Well, I already know what part, but how do I make it happen so that we can become a critical access, or we can become a rural emergency hospital? What does that look like? We can explore some of those. So it's not a time for us to just sit back and go, okay, well, we got an additional $3 million, we're done, right? Like that's not it. We're really taking that sales tax as this just buys us time to really get us set and get our footing correct.
Correct.
Right.
Yeah.
So that's one piece. The other piece of the transparency piece, you are correct. Like it is a private board, and so we don't have to share our minutes. But I did assure the city commission when we took the very first work session was, well, how's the dollars going to be used? And I'm like, here's what we're looking at, right? It's capital equipment. We're really behind. It's not that things aren't working today. They're at the end of life.
Right.
They're really old, right? And so if they break tomorrow, most pieces of equipment in healthcare are like $1 million, right? Like a CT machine is $1 million. So those things add up pretty quickly. And we have our senior team. This is our job, and so we went through in our critical, like, this is not the fluff. This is not it'd be nice if we had that. It's the
right.
If
Essentials.
it breaks tomorrow, how do we come up with these dollars? And we have about $2.6 million of critical equipment needs, right?
Wow.
And so it helps that. It buys you that time. It helps you find the funnel of somewhere else, right? There are grants. Trust me, we're really good at writing grants now. We're getting better and better. But there's some of those avenues, and we will still explore those. Yeah. So I think that comes from that. But the other part of that is at the work session meeting, they just point blank, they were like, so will you come back and share your financials? And I'm like, absolutely, cool. Right? Even at one of the very first work session meeting, actually, I shared our profit and loss for since 2017, right? And that's hard to share. I'm just going to be honest. We went through some times, like we kind of talked about early on, that administration spent a lot of money, and that is what it is. I can't fix that. All I can do is move forward from it, and we can show you that in the last 2.5 years we've made a lot of stride, and we'll continue to make that stride.
That's good.
And we'll be open with that. I'm happy to give you a list of, we don't have anything to hide.
Sure.
Really.
So that I love that answer. So there is a place where you've provided some transparency specifically with the commission, which our community has elected.
Yeah.
They're there for a reason. And I appreciate you partnering with them on that. That's great.
Yeah. Yeah.
I think that really squashes some fears of people that I've talked to of like, is there going to be any type of partnership or collective, right? Of like, this is our money. And
yes.
like, what does that look like? So that's great. So talk about the business unit itself is a hospital. It employs a lot of people, but what is it to our community? Like, it's not just a hospital. What do you think SBA is to our community outside of just healthcare?
Sure. Yeah. So it's the cornerstone. It's one of the cornerstones of El Dorado, right? I hear a lot of, I have the opportunity to get to sit on, several different meetings throughout the community. And it's a lot of like, how are we going to grow? How do we keep jobs here? How do we keep people living here in El Dorado? And without a hospital, that's really hard to keep.
Yeah.
Right.
Yeah.
I actually had a great conversation with Sarah at El Dorado Inc. And I said, what does it mean for you if we don't have a hospital? And she was like, listen, I don't know, but every paper that I usually have to fill out from what do we have to offer here, one of the questions is there health care in your community? And so she's like, I don't know. I can't specifically tell you, but I'd say I'd hate to mark the box no.
Yeah.
And so I think that's pretty impactful. We employ, we have about 293 positions throughout our organization, so last year we paid $16.4 million in wages, right? So and most of those people they don't just work here, right? They're shopping here, they're going to Dillon's, they're going to Walmart, they're doing all their grocery stuff, they're doing all the things right here. And so those dollars will go somewhere else. And I think, it's not about just the hospital being gone, but truly you will lose the care that is provided. So, I mean, I'm not here to like talk bad about the big hospitals. They have their own things to worry about. But what I can tell you is I hear over and over the patients that go there. In fact, I know some of the providers that work in that ER and they really struggle with the fact that, like you wait in the ER waiting room for 4 or 5 hours, right? And then even if you need to get admitted, you literally sit in a hallway waiting for a bed to open up. If we're not here, that's even more of that.
Yeah, add a half-hour drive plus.
Yeah, and it's, I understand if you had a bad experience with us one time, right? I understand that's hard to let go of. But the reality of it is if we're not here when you really need us, it can be detrimental to not have it here,
Well, my grandma needs you guys here. There's been multiple situations where that would have not worked to go to Wichita, right?
Yeah.
So
Yeah.
that's the part that at my core, the fear I have, right, of something like this not going through, regardless of it. And I appreciate your answer. Like, we'll continue to exist, but we probably won't be able to improve at the rate we could for the community, right? Like, that's like, where could we invest $2 to $4 million a year on that 1%? And also the cool thing, if you guys are, I'm throwing out a number that I might have found. Melissa's not saying this. Around $40 million a year, you're talking about potentially 5 to 10% revenue increase that's got no overhead against it and complication in billing, right? That can come in and affect change quickly. And I love that. That free and clear cash can solve problems really quick.
Yep.
And everything you're saying in your vision, I think, is going to be attack those improvements, show out those improvements, and make sure the community feels it, right?
Yep.
And with that at its core, I think that's exciting.
Yeah.
And that's something I can get behind on a 1% sales tax. And there's been other ideas for this 1% sales tax, but I don't think there's been anything as meaningful as this and what the hospital means for the community. Not to try and influence people, because I have been accused of that before. But if you can't tell, I'm going to vote yes. And I hope others vote yes as well. And that is the vibe I'm getting, by the way. I think the vibe I'm getting within the people I'm talking to is the majority are are a yes. So
Yeah.
any final words for you? I'm going to let you go, but
Oh gosh. Yeah. I mean, I hope that people in the community just in general understand how valuable and what they really have in their back door. I mean,
Yeah.
to just be honest. And we have an entire team of people that are so passionate about just making sure that their loved ones that live right here have somewhere to be cared for at the level that they want them cared for. You know, and so that's what SBA can bring.
yeah, that's good. Appreciate you coming on. You're awesome. Glad
Thank
we
you
met.
so much.
This was a blast.
Our stories of life are really in line.
No,
It's just
I'm
kind of
excited.
fun.
You and my wife need to get lunch sometime. I
Yes.
think she could not only learn a lot from you, but you also have shared
Oh,
experiences.
my gosh, and yes,
and
that'd
she's
be-
just starting her career, so she's enjoying it, and also it's a lot.
Yeah.
right?
Yeah. Oh,
Healthcare's
yes.
changed a lot.
It
So,
is, yes, for sure.
Yeah,
So thank
I
you
love
so
it.
much
Yes,
for having
of
me.
course. Thanks
This
for
was my
coming
first podcast. It's
Of
great.
course, man, you're
Super
awesome.
fun.
You're
So-
natural.
Oh,
No,
well, thank you.
that was good. Thank you so much for your time.
Yeah, thank you.